everyone. I want to welcome everyone to our April Provider Forum. We have Jody Goodman and Tiffany Veal with Haven Hospice, along with Dr. Massey. And we're going to be talking about palliative versus hospice services. So I'm going to let Jody start with introductions and let you know kind of what we're going to be doing.
Hey, good morning. I'm Jody Goodman. I am the Executive Director for our Business Development team here at Haven Hospice and Palliative Care. I cover our business development team as well as our volunteer program.
Hi, I'm Tiffany Veal. I'm a patient care representative for Haven, and I cover Bradford County, Gainesville, and some other areas on the East Coast.
Dr.
Hi,
Massey.
sure. Hi, everyone. My name is Tiffany Massey. I'm the Executive Medical Director of Haven Hospice. I have been with Haven for the last, I believe I'm going on 8 years. I've had various roles within the organization from a staff physician, associate medical director. I ran our access admitting department for a few years. And in the last couple of years, I have become the executive medical director. I currently oversee, I believe we have 7 current physicians right now. And I think we're up to 20 nurse practitioners that I have that are doing palliative care and hospice services with us. So I'm happy to be here. I'm familiar with your program, the ARC. I attended a fundraising event at the ARC in Jacksonville. I want to say maybe 2 to 3 years back, and I got to see do a wonderful tour of the facility. It was just a great experience. This one was, I would say, on the south side of Jacksonville, and I'm born and raised in Jacksonville, so this is my hometown. So I was excited to get the opportunity to come back and speak to you all. Is most everyone on this call providers, administration? Who all am I speaking to? If you don't mind telling me.
I would say the majority of this is geared toward small and medium providers.
Okay.
You will have some direct care staff and some waiver support as it's open to the public, but it's geared toward the provider aspect.
Perfect. All right. Will you let me know when do you need to make any announcements or are you ready for me?
No, we're good. You can
Okay.
go ahead and start. And Jody has is sharing the screen.
Sure. So we'll start off with just this picture of Cicely Saunders. Of course, she was the founder of the hospice movement. I love this quote that she said often, "You matter until the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to live until you die." And that's part of our motto is, quality of life versus quantity of life left. Just what can we do to help patients and their families enjoy their life right up until the very end? You can move, Jody. So objectives of this program, our goal is to define palliative versus hospice, distinguish appropriate time frames to use palliative care and use hospice care. We want you to understand the benefits of both and how we can specifically help the ARC of Florida. So what is palliative care? They use the word to cloak or to cover. Basically, we're offering, you can go ahead and move with that one. Basically, the intent of palliative care is to cover pain. Our goal is to provide symptom management without affecting the disease. So palliative care is the active total care of patients to prevent, relieve, reduce, soothe symptoms of disease without affecting a cure. We want to treat the whole person. We want to promote quality of life. We want to align with the person and honor their goals of care, goals of end of life. Curative is more quantity of life and trying to prolong life, where we look at palliative care focuses more on quality of life. I think this is a really good slide. Curative is more working towards the cure, and palliative care is more trying to relieve the suffering through symptom management. With curative, we're focusing more on the disease process. With palliative, we're focusing more on the family and the patient structure. Both of them are working on symptoms. Symptoms are clues for disease with curative, but in entities themselves with palliative. And then, death is the ultimate failure with a curative model. And then in palliative, we look at it was the patient able to pass away comfortably? Do we look at their death as a success? Were they able to have their goals end of life goals met. So palliative is viewing the entire individual from a physical, emotional, social, and spiritual dimensions to make sure that we've kept them comfortable. So all hospice care is not considered palliative care, and all hospice is considered palliative, and all palliative care is not considered hospice. So I think this is a good slide that kind of breaks down. For both of these models, we do not need any type of DNR. We're happy to have patients in palliative and on hospice that are full codes. For palliative care, of course, you don't need any type of pre-approval for chemo, radiation, transfusions, those types of things. With hospice care, we'll get into this later on in the slides, but we're an open access hospice, but we would still need pre-approval for treatments. Under palliative cares, for patients that either don't choose hospice or are not eligible for hospice, sometimes patients aren't eligible because they're seeking this aggressive treatment or they're just not ready for the word hospice yet. For palliative care, no reimbursement sources, and then in hospice, reimbursed is a benefit. Hospice is a benefit and can be reimbursed. Both of these programs are interdisciplinary, and both of these programs support both the patient and the family unit. And then with grief, it's more anticipatory grief with a palliative care model. And for hospice, it's both anticipatory and bereavement. We actually provide bereavement services for 13 months after a patient passes, because we see that usually at that 1 year mark, patients and their families are still having difficulty. And that 1 year kind of brings everything back up again. So we usually go for about 13 months of bereavement. Palliative care is and what it's not. So it is a philosophy of care. It's not a treatment modality. It does manage spiritual, social, the suffering. It's not restrictive to only pain management. It's best utilized at the onset of a diagnosis and throughout the whole course. And it's not usually utilized at end of life. Usually we're calling in hospice at that point. It's definitely a collaborative, interdisciplinary effort with the family and the team. And it's not limited to only a palliative care physician and utilized for any life-limiting illness. And of course, it's not just related specifically to cancer. So we ran, I wish this was one of the pictures of our nurse practitioners. Our providers for palliative care, or even physicians or nurse practitioners, like I said, I believe we currently have 20 nurse practitioners in the 18 counties that we cover, and 7 physicians, including myself, would be 8. Palliative care is addressing the quality of life issues, being with someone versus doing for them, and we use an interdisciplinary team approach. This is a good slide that shows curative focus and then a palliative focus. So the curative focus is, of course, in orange, where we're using disease-specific treatments, the chemo, the radiation, the transfusions. Palliative is using more comfort and supportive treatments. And then we see that patient at some point where they continue in a transitional phase and they're declining. And then we are able to move them on to hospice care. So the beauty of how we do things within Haven, I think with this slide, is that you actually get to see the same person. So I think that it provides a huge comfort for families when we had you on as a palliative care patient for a year or 2 years or even 6 months, and then that person declines and we move them on to hospice, because of how we cover our 18 counties usually can stay with the same provider and they can cover you for hospice care. And usually our bereavement coordinator would be the same one that would work with you with palliative, that would work with you while you're on hospice. And then we would move into bereavement. So palliative care symptoms that we try to address, of course, lack of energy, worrying, depression, feeling sad, pain, nervousness, drowsiness, dry mouth, difficulty sleeping, feeling irritable. These are issues for quality of life that palliative care would try to manage. And we see this so much in elderly population and our dementia population. So these are the main symptoms that we try to manage. So when to consider palliative care, this is very important. So whenever your patients or the individuals at the ARC have an unacceptable level of pain, they have spiritual issues, psychosocial issues, they need some complex decision making to determine their goals, their code status, end of life issues, frequent hospitalizations, especially recurrent readmissions, prolonged length of stays in a hospital, and just a general lack of improvement in their overall condition is when you all, as physicians, providers, nurse practitioners, again, whoever's on this call, is when you should start considering palliative care. So barriers to palliative care, usually from the family and the patient, is, of course, it's very hard to say, you know, I'm giving up. We don't look at it that way, but of course, that's how families see it. The family and the patient want to deny how severe their disease process is. A lot of misconceptions, you know, the elderly are fearful of becoming addicted to pain medicine and fearful of adverse treatment effects. Just lack of information about treatment options and how they can manage end of life. And then obviously we have many different ethical, spiritual, and cultural beliefs, and we take that very serious with Haven, that we try to honor and support these different ethical, spiritual, and cultural beliefs, especially as we're approaching end of life. Everyone has, you know, ways that they need to be that they want to be with their family, ways that when they pass away, how things have to be done. So it's nice with palliative care to kind of talk that all out with families and make sure we're honoring them as we approach end of life. So barriers to palliative care from a medical standpoint is it's difficult to accurately predict end of life. We've all seen a patient that we're kind of shocked by. I mean, that patient went down so quickly. So it's very difficult to say an exact prediction of when we anticipate someone's going to pass. Just healthcare providers' reluctancy. Everyone again has the motto that, you know, we want to keep working and trying to get the person better. And so it's difficult to kind of let loose. Lack of integration within the healthcare system, a disease-oriented approach to patient care, and then of course just limited medical and clinical expertise in palliative care. It's a new field, right? I mean, it's not new, but it's newly talked about, and you know, we're getting it out into the community, but people don't really understand the difference of palliative and the difference of hospice. Financial and regulatory obstacles, and then again, the same as ethical, spiritual, and cultural different beliefs provide some barriers. And then, of course, the benefits, just less futile, redundant care, and improves continuity between settings. We see a lot fewer ER readmissions, a whole lot less hospital stays, fewer hospital deaths, easier to discharge a patient to a long-term care facility, reduced length of stay in a hospital, because we're able to honor patients' goals. We've talked about these things. We're all on board with how to treat the patient. We can help manage symptoms that they have at home so we don't have to return them to the hospital. We can help manage symptoms so they don't have to go back to the ER. And then specifically, again, for ARC patients, you know, Haven would provide visits for the patients where they call home. My experience with the ARC is there was a community setting in Jacksonville, and don't hold me to it. I believe you had about 25 different residents and multiple roommates. And so we would actually come to your facility and do house calls and help manage those symptoms to avoid the inconvenience of taking someone to an appointment. I mean, we all know, I'll talk about my mom throughout this presentation. My mom has metastatic breast cancer, and just on a personal level, trying to get her out to an appointment. I mean, I have to worry about what car I have. Do I have the wheelchair? Is the car too high? Do I have the cushion? Do I have the plug to get the oxygen and get her loaded up? So it's such I don't want to use the word inconvenience with my own mother, but it's an inconvenience to try to get someone to doctor's appointments and to help organizing the transportation. At the same time, it wears her out. It wears me out. You should see us when we get to a doctor's appointment. We're both sweating, like literally sweating, because I mean, it was just so much to get her out and add like a raining day and trying to hold an umbrella and push a wheelchair and carry her oxygen. It's just a lot. Well, at the same time, my mom gets extremely anxious from all of this. You know, she's worried I'm going to drop her out of the wheelchair. She's worried I'm not strong enough to push her. She's worried because I should be at work and I shouldn't be taking her to appointment. So us coming to you, I think, will really help your patients. We, of course, will manage the individual symptoms. of each consumer, and we will write the prescriptions for you. So most of our patients still see their primary care doctor, but we can be that middleman. So you've ran out of prescriptions for your high blood pressure meds and you don't have your follow-up appointment for 2 more weeks, we can give you medicine for that. You're having an episode of nausea and vomiting and your doctor can't see you that day, we can help manage that. You're really anxious and you've been having some feelings of hopelessness and depressed, we can start you on an antidepressant if needed. So those things that we can do as the middleman. Also equipment. So we can help get the medical equipment that someone might need versus them going to the palliative care doctor. This probably doesn't affect your population, but driving and disabled parking permits and all the things that we can do from a medical standpoint that doesn't involve you having to go out and make an appointment and see someone. We will, of course, review the medications and we will provide any additional recommendations. We will start what we need is a referral, so a support plan, and then clinical notes from the last time, your last medical appointment, so we can review those. And then again, just the plan of care of information from scheduling, who would we speak to at the group home, proxy, and any demographics that we need on the patient. Go ahead to the next one. And then reimbursement sources. We, of course, at Haven do philanthropy work. We're happy to see patients that do not have insurance. We're happy to see patients that are uninsured or underinsured. We totally support patients that still need our services. Reimbursement sources also come for a fee for service. And then there's direct hospital support. And then usually Medicare Part B, for a consult by a physician, the nurse practitioner, and our social worker are our reimbursement sources.
And Dr. Massey, if I can just jump in, when we go back to needing a referral, really all you have to do is call your patient care representative. So Tiffany or each of the ARC buildings would have an assigned patient care representative, and I'm happy to get that information out to everyone. And a phone call to them, and they can help you figure out exactly what you need to make sure that your consumers get the help that they need.
Thank you. So expanding the concept of healing. So at end of life, the nursing care transitions from a focus of wellness and recovery to an understanding of healing. So we really try to promote holistic healing approach for the family, where not so much that you're going to recover from this illness, but what can we do to make your symptoms feel at ease so that you feel we have you in a much more comfortable state as we're approaching end of life. So who qualifies for hospice? So this is my kind of meat and potatoes of the job that I have with Haven. So we really look at these patients that have been on palliative care and now they're transitioning to hospice. And I get this call, probably 20 to 30 times a day. I've had one already during this meeting where I get a patient presented to me of who qualifies for hospice. So anyone with a terminal illness, when 2 physicians certify that they expect the patient to pass away within 6 months. I do not have to be correct here. I can say, I think you're hospice appropriate, and I can say that I think you're going to pass away in 6 months, and you can still be on hospice services and you can last for a year, 2 years. In those situations, we just anticipate that we see decline. A patient is acceptive of palliative care. Most patients are covered under our Medicare Part A for hospice, and most insurance policies and Medicaid policies have a hospice coverage. And then if there's no coverage for hospice, then Haven will bill the patient on a sliding scale with no health insurance. So we do something called an IFA, and we look at and we see what the patient's financial situation is, and we have a bill on a sliding scale for patients. The interdisciplinary team for hospice is so important. My background before I went to medical school is I used to be an occupational therapist, and this was the part of my job that I loved the most. I worked with the interdisciplinary team. I had the physician, the social worker, the nurses. We all used to sit around and talk about our rehab patients' progress. And I'm kind of in the same role now in a different level, but our interdisciplinary team is just wonderful. There's not one of us that plays a bigger part than the other. I tell my team that on a weekly basis. The physicians, the nurse practitioners, our nurses, our hospice aides, our social workers, chaplains, our bereavement counselors, and our volunteers. It's wonderful to see these interdisciplinary teams come to work for the patient and the family to meet the physical, social, spiritual needs of both the patient and the family. I think some of the ones that go unrecognized are like hospice aides, but sending someone to the house to a community and to help someone with bathing and to kind of take that burden off of, a daughter having to bathe her father or a mother having to bathe her adult son, just to give that patient the dignity and have a hospice aide do this is beautiful. Our volunteers do so much. I could tell you story after story of volunteers where, mom wants to get her hair done every Thursday and she's, wants to stay with her loved or her husband. She can't leave him, but it's really important to her. That's just something that makes her feel better about herself. So we send a volunteer out for 2 hours a week so that mom can go out and go to a hair appointment and come back, or go to the grocery store and come back and feel, hey, I've got someone at the house watching him. Now, our volunteers aren't going to dispense medicine and turn the patient and get them up to go to the bathroom, but, stay with them for a period of time so that the family can still do stuff. We also have the bereavement counselors, and they work on both anticipatory grief and post-death bereavement. It's so important for someone, especially when we see people passing away at a younger age. There's so much anticipatory grief. It seems like more, in a society, it's more expected that we're going to pass away towards end of life at an older age. But seeing some young people, it's so important that we have anticipatory grief counselors. And then, of course, our chaplains, just to provide spiritual support for our families, our social workers, the psychosocial issues, proxy, everything from, helping with, their finances and figuring out things. And of course, our providers and our nurses. Our nurses are just wonderful at Haven. They have such a rapport with our patients, and they know them so well. It's very touching if you ever were to sit in one of my interdisciplinary group meetings. I've been in one of those earlier today because we do a bereavement piece and we talk about each patient that we lose on hospice, and to hear the connection that the nurses, that the entire team has with these families, honestly, much more than I have. I've maybe seen them 1 or 2 times, but these nurses have seen them 1 or 2 times a week for, 6 months. They have such a rapport with them. So our entire team works together to address these and support the patient and their family. So eligibility determination. So disease-specific criteria is based on how is the disease progressing? How is the patient functionally doing? What comorbidities do they have? What conditions are contributing to their overall decline? Can we look at any labs or diagnostic tests to help me determine eligibility? And have they decided not to pursue any more aggressive treatment? So this is our FAST score for Alzheimer's patients. And I don't know if any of you use a FAST scale, but the functional assessment scale, we call it FAST. Usually for patients to be hospice eligible, we like to see them in the 7A ability, which means they have an ability to speak approximately less than 6 intelligible different words in a course of an average day or an extensive interview. Sometimes we see people coming on hospice service at a 6 level where they're improperly putting on clothes without assistance, unable to bathe properly, inability to handle toileting, urinary incontinence, fecal incontinence. To come on for a straight Alzheimer's, I usually like to see someone at about a 7A level. But again, if I can list some additional comorbidities and show some additional functional decline, and this family doesn't want to pursue any more treatment, it would be okay to bring them on in the 6 score range, as long as I can add some additional comorbidities to make them hospice appropriate. This is our palliative performance scale, and we call this PPS. You hear the word PPS. Most patients that come on hospice service are living somewhere between a 40 and a 50% on the PPS scale. When I have a patient that's considered totally bedbound, that puts them at the 30% mark. But most of our patients are mainly in bed, are mainly sitting or lying, unable to do extensive work, unable to do a lot of activity, need a considerable amount of assistance, and their conscious level is they're full or a little drowsy. So maybe some lethargy. Again, but I wouldn't expect someone to come on service at 100% and 90%. We do sometimes see people with high PPS scores, and that's usually when we see someone who has a newly diagnosed metastatic cancer, and we understand that the trajectory of cancer is going to kind of go straight down. So it would be okay for us to bring someone on with a metastatic cancer because we expect if they're not going to explore curative routes, that they would decline rapidly over the next 6 months. Activities of daily living. So we use this slide to provide evidence of declining independence. We give an ADL score. We say 1 out of 6, 0 out of 6, and it measures these 6 components: bathing, dressing, eating, transferring, toileting, and continence. So someone who's truly at end of life is usually considered to be a 0 out of 6. Meaning that they can't even feed themselves. A lot of our patients live in the 1 to 3 out of 6 range, meaning that they maybe can still feed themselves, but they need some assistance with bathing, need some assistance with grooming, those activities. So Alzheimer's disease and dementia, this is our main diagnosis. And this is kind of what I spoke on earlier. So to come on for an Alzheimer's disease, we usually like to see patients with a 6 or 7. To be eligible for hospice services as using hospice as the primary diagnosis, it has to be at least a 7, and usually we start with a 7A. Usually with Alzheimer's, we see comorbidities, which include recurrent urinary tract infections, wounds, multiple falls, difficulty swallowing, dysphagia, and we add those as comorbidities that kind of wrap up a package and show a functional decline. The FAST scores usually don't improve, and so once we see a FAST score of like a 7A, we wouldn't expect it in 2 to 3 weeks to be a 6 where it's gotten better. We would expect it to continue to decline. And we only use a FAST score in Alzheimer's patients. We don't use it in like frontal lobe dementia, senile degeneration of the brain. We only use it under Alzheimer's. So the picture of late Alzheimer's disease, this is just where we're starting to see severe cognitive decline. They're not verbal, they're grunting at times, incontinent of urine, usually need assistance with feeding, with toileting. They've lost basic psychomotor skills. They're not walking. They have poor trunk control. They can't sit up without support. The brain's not really telling what the body to do. And you see just generalized and cortical neurological signs is usually a picture of late onset Alzheimer's. And of course, the patient is clearly appropriate for hospice services at that point. So our next high disease that we see for hospice services are cardiopulmonary issues. So this includes my CHF, my COPD, pulmonary fibrosis, coronary artery disease. This is where I usually am looking at functional impairments more. I usually want to see that the person's having shortness of breath with rest, usually that they're on oxygen, dependent on oxygen. They've tried maximal medical management. They still have ongoing chest pain. They still have shortness of breath. They still have edema. And I also would include comorbidities contributing to their decline. So I might say, hey, this person has congestive heart failure. They have an EF of 30%, but they also have had recurrent falls and dementia. And so kind of that total package makes them hospice appropriate. Again, we normally like to see a PPS at about 40%. And I would document this. We write what's called a certificate of terminal illness when we bring somebody on service, proving their eligibility. And so it's really important that I show this functional decline. And functional decline may may look like the patient used to be able to walk out to their mailbox and get their mail, but now they become very winded just walking to their bathroom, which is only 10 feet away from the couch. And it takes them 2 minutes to recover after they do that short walk and catch their breath. So those are things that would, again, show these functional impairments. So cancer, again, all cancers that are considered metastatic and advanced are hospice appropriate. We say stage 4 cancer, but a non-curable cancer is always hospice appropriate. The patient could still be receiving some palliative radiation or chemo. We would look at that. I think I have a slide about this in a minute talking about open access, but we would look at that on an individual basis and determine the cost and the appropriateness. And I try not to blanket approve things, because I'm trying to be, protective of Haven's money, to be honest with you, but also we don't know that the patient can tolerate it. So if I approve 10 radiation treatments and they could really only tolerate 2 or 3, we don't want to pay that all up front. So, we usually would say, like, let's try 2 sessions and see how you do, see how you tolerate it, see how your symptoms are, if you even want to continue with that before we would proceed with approving the next step, so to speak. And then, of course, we document evidence of disease progression. Usually I have a CT scan or a PET scan that shows, metabolic uptake in new areas. My liver lesions have increased, looking at oncology notes. Usually my patients have a PPS of 40, but again, it can be much higher than that with a metastatic patient because we expect them to decline rapidly if they're not going to pursue treatment. So for renal disease, usually we can use a chronic kidney disease stage 4 or an end stage renal disease. We look at, again, functional impairments such as shortness of breath, edema, any type of generalized weakness, recurrent falls, and then of course comorbidities. Do they have CHF on top of this and they're just, they stay volume overloaded? Are they having, hyperkalemia? Have they refused dialysis? And usually a PPS, again, is around 40 to 50% or less. Liver disease, this one we look at specific labs. So we look at a prothrombin time, usually that's greater than 5 seconds over what a normal control is, and an INR that's greater than 1.5. And we look at albumin. We want to see the albumin is actually less than 2.5. And then for refractory issues, usually my liver disease patients have esophageal varices, they're bleeding, hepatic encephalopathy, usually hepatorenal syndrome. They have ascites. They're possibly been hospitalized for sepsis from bacteremia, peritonitis. And again, we look at comorbidities. Usually we see poor nutrition, muscle wasting. Sometimes this is related to alcoholism. Usually there's a hepatitis involved and hepatocellular carcinoma. So usually my liver disease, again, if you don't have every single thing, this is a great example. If your PT isn't exactly where it should be on labs and your albumin is maybe like 2.7, but you've had 3 hospitalizations for ascites, you've had to be drained, I've had to put in a Pleurax drain and do a paracentesis on you, you've had to be banded for the varices that keep bleeding, the patient would be appropriate. Again, so you don't ever have to follow these numbers and these labs 100%. I just have to show that you're kind of close to it and that your comorbidities and functional decline all show us that you're headed towards end of life. The next one is neurological conditions. So this, of course, is my things like ALS, the dementias, the Parkinson's disease. With these, I usually see swallowing issues, the patient's non-ambulatory or they are ambulatory with recurrent falls, usually dependent in ADL care. Usually that PPS, again, is about 40. And again, UTIs, wounds, aspiration pneumonia, recurrent falls are all things for neurological conditions that we look at and can list as comorbidities. And then supporting documentation. So we need a referral diagnosis. So usually when we would ask for a referral, we would get what's the most pertinent admitting diagnosis, whether it's dementia, CHF, a cancer. We would, of course, review medical records. And then we send out our nurses and they take a history from the patient and family and look at everything from symptom issues, how they're managing their self-care, those ADL functions. We look at what can the patient do, changes in weight, BMI, definitely look at weight. We look at weight loss. And then of course we look at any diagnostic test, any imaging, any labs that we can evaluate to determine if they're eligible. This is like my Haven homework. I say I do this situation like 20 to 30 times a day. I get a patient and they tell me Sally Smith is coming on for breast cancer. And obviously that's an appropriate diagnosis. And then I compose a narrative and I report what her PET scan shows and I report what treatment options she's undergone and how they've probably been unsuccessful or what side effects she had from the chemo or the therapy and why she wants to stop. And then we also look at an evaluation of where were you 6 months ago. So when I write these reports, I say, well, 6 months ago, she was driving her grandkids to soccer practice and she went to the grocery store and now she's bedbound and she needs assistance with turning. And when she sits up, she needs pillows to support her trunk. And she's had an episode of aspiration pneumonia and her ascites is getting worse. And she's been noted to have a pleural effusion and had to undergo a thoracentesis. So showing that picture of this decline from a 6-month process to where she is now supports this documentation and it determines eligibility, helps us when we document that. And then Haven uses an open access model. So I really want to explain this to the ARC and we evaluate every single patient on an individual basis. So we don't just say, yes, we can do everything. But what we mean by open access is we would still consider chemotherapy for some patients. We would take patients that are on a pre-transport list. We treat patients with mental health. We've had patients who have still received some dialysis sessions. We treat pediatric patients, bariatric patients, patients that need radiation treatment. We continue to give patients antibiotics. We can do oral antibiotics. We can do IV. We've used TPN on patients. We've used IV inotropes. We, of course, have treated many patients on a ventilator on BiPAP. We offer therapy still. I have 2 patients I approved therapy for today. Safety for their loved ones to assist with transfers. My other patient really wants to try to ambulate and he just doesn't feel like he has the strength. So we provide 4 to 6 sessions of therapy. Wound care, we have a wound care specialist. We're trained in wound care, but we also have specialists that we can send out. Transfusions, paracentesis, and thoracentesis. So all of these things, I would say in a week, I have approved. We have pediatric patients right now. We definitely send patients for thoracentesis. I put Pleurex drains. We send patients off to IR and we get Pleurex drains placed on patients. We continue to do transfusions. I'll give you an example of like a leukemia patient. So if this person's probably needing to be transfused every other day, that would probably be considered aggressive treatment. That patient might be more appropriate for a palliative care standpoint. But if this patient says, you know what, it's April 7th and my grandkid's getting married on May 1st. And, I really want to make it to this wedding and I don't want to go to the hospital every day and get this transfusion. But if I could maybe get transfused twice a week until this wedding, like that's my goal. Would you approve that? And we would certainly approve that. And we would hold, I think it's neat what Haven does is we hold a complex case on any of these patients and we bring in the interdisciplinary team because again, it needs to be a joint decision. And, the nurse might pick up on something that I'm not aware of. The chaplain might pick up on something. So we have a 30-minute call and it's called a complex case and we discuss open access. What can we do to help this family? To be honest with you, we do look at the cost and what does this cost in Haven? We're also a business, but how can we help this family? And if it's something that is within our financial means, we usually will approve it. I have a few patients in the last week that I've approved a couple of dialysis for. They're normally getting dialysis 3 times a week, but they're like, hey, if you could maybe just let me go once a week for the next 3 weeks, I think that would hold me over. My son's coming home for spring break and, I really want him to be here, but I don't want to go 3 times a week. Can we do that? And we would approve that. Tons of antibiotics. I'll just speak on antibiotics. When you come on hospice, we still treat the pneumonias, we still treat the UTIs, we still treat the cellulitis. We, of course, would prefer to use oral antibiotics because that's less invasive to the patient. And honestly, it's more cost effective. But we all know that we obviously have times that those oral antibiotics aren't appropriate and we have to use IV meds, and we would certainly approve that as needed. So when is it time to consider hospice care? I ask you to ask yourself, would you be surprised if this patient was alive in 6 months? So would it shock you if you heard that Mr. Smith, had passed away in 6 months? If you kind of have that thought process, then it's time to consider hospice. Has this patient continued to have a steady decline? Are they going back and forth to the hospital? They're in the hospital, they're back home for a couple of weeks, they're right back there again. CHF exacerbation, a COPD exacerbation. Their cancer has progressed. They've got volume overload. They've got ascites, just in and out of the hospital. It would be time to consider hospice. Have they had a progressive weight loss? Anybody that's lost more than 10%, more than 10% of their body weight, we consider that progressive. And we can even admit patients for what we call moderate protein calorie malnourishment, where they've had a weight loss, they're not eating. We can show that, they've lost 10% of their body weight. Increased fatigue, weakness, poor performance status, declining cognition, again, poor nutrition. They have multiple wounds that aren't healing. They have a long list of comorbidities. And again, do they have a specific diagnosis that's kind of the ringleader that's causing this? And if not, if they have this long list of comorbidities, then we would use that, a combination type diagnosis. And then have they expressed to you that they just don't really want to do this anymore? We all know that patients will say things like, I'm ready to pass away. I'm ready to stop this. I don't want any more treatment. I want to go see my late husband who's in heaven. I want to, I'm ready to go. When we start hearing our patients say that, I think internally that they're feeling it, that it's a good time to call in hospice. And these are my resources. And I think that might be my next, just one person. Let me go back to that. I love that quote there. If you can go back one, let's see if we can figure this out. One person caring for another represents life's greatest value. And I'll just tell you, from my heart, that I feel like this is my ministry. Hospice is my ministry. I used to be a hospitalist, and, it was just so aggressive and trying to get everybody well and in and out of the hospital and trying to discharge the patients before noon and, trying to see 25 patients in a day. And that just was not for me. And I came over to hospice. I did a fellowship in hospice and palliative care, and being able to be with someone at end of life is honestly a blessing. I think as society, we're scared of end of life, and we're scared of talking about end of life and dealing with it. I always say you have one opportunity to have a really positive birth experience, but you only have one opportunity to have a positive death experience. And we really at Haven want to be there for our patients and for their families. We want to honor their goals of care. We want to get their symptoms managed so that they're not under any stress or anxious, and help them pass peacefully on our program. So that concludes my presentation. I appreciate you letting me spend time talking to you. I'm happy to answer any questions. I'll do my best. I might recruit Jody and Tiffany to help me if needed. So take it away.
Well, we don't have any messages in the chat.
Okay.
So we'll open it up. If anyone has a question they'd like to ask, you can unmute and ask your question. Or if you prefer, you can type it in the chat.
Perfect.
And it looks like right now we have a quiet bunch.
Okay. Well, that's
They're
okay
soaking in
too.
all the information.
And I'll be happy to, Jody, if you could possibly enter my email in the chat, if there's any additional questions I can answer. Again, I'm very familiar with your program. I personally will be overseeing this at the ARC. So if we are able to support your program with palliative care and with hospice, it will directly, the calls will come to me. I like to describe Haven as a mom and pop organization that got big, but we still practice on mom and pop principles. So I guess I'm mama bear, and the calls still come to me. I'm not a figurehead. Like I'm very much, I still take call every day, Monday through Friday. If you call in the middle of the night, the call comes directly to my cell. So we still operate as kind of a mom and pop organization. And I would love to help you. I'd love to answer any additional questions, and I'd love to help your patients. I think what you all are doing is wonderful, how you provide for the community. I'm trying to learn more. It sounds like y'all are in multiple counties throughout Florida as well. So, and y'all are growing. So again, we just appreciate you giving us the opportunity to speak today.
Great. We appreciate it so much. And we'd like to include a copy of the presentation to all attendees, and we will include your contact information as well.
Wonderful.